I mean, the other question I have is it's a big question, so I'm sure I can find it in
All
some
right,
of your other
ask it.
videos.
Just go ahead, ask it.
It just has to like I'm trying to how I can better understand like the respiratory stuff with the I know you gave the acronyms, the CCED like for croupy cough and then the epiglottitis,
Okay. So
drooling and
look,
that
hold on.
stuff.
So okay, so you're talking about primarily pediatric respiratory conditions, and I use CC'd like you CC'd somebody on your email, and
Yeah.
that is croup or croupy cough. So this
Mm-hmm.
seal-like barking cough is for croup, and then with
Oh.
epiglottitis we have drooling. Okay,
Mm-hmm.
also known as salivation. Now, but what's your question?
Is like where so I'm trying 'cause I like the pictures and stuff. I'm just trying to like remember like because a lot of the questions ask you like, okay, is it um like when for example like okay they have a seal like bark, okay, so
Okay,
is it going to be a upper or lower respiratory, and so it's
okay.
just trying to
So
figure
we're
that
going to
out.
call this a seal-like barking cough.
Hmm.
That's a way basically they're when they use seal-like bark or barking cough, seal-like barking cough, they're pointing to croup. What is croup? So croup is so the official name for croup is laryngo, tracheo, bronchiolitis. Okay, let's break that down. Itis means
Inflammation.
okay, so we got swelling. Swelling of what? Swelling of the boom, boom, boom. What are those things? Okay, so let's do our airway. So we got to start with just knowing basic airway anatomy.
Hmm.
So of course we've got a mouth, we've got a nose. So let's call that a mouth and a nose. So air comes into the mouth or the nose, right? And then it
Yeah.
goes through, it gets into the, okay, so this part here, that's going to be called the, we have what's called the pharynx. And by the way, it's pharynx. Wait, pharynx. It's not pharynx. Okay, don't pronounce it pharynx. It's pharynx, larynx. Okay, so you want to pronounce it like rinks, RANKS, like a skating rink. Okay, so pharynx and larynx. Now the larynx, that's your voice box.
Hmm.
Okay, but then it branches off into, now we're going to get into the trachea, and the trachea has these rings, these cartilaginous rings. Then we get into our lower airways. And now, so these big ones here, those are called the, uh, one of them is called a bronchus. If we're talking, so we have a left bronchus and then we have a right bronchus. But if we're talking both of them, the plural is called bronchi.
Hmm.
Okay. Bronchi is plural. But then we get into the smaller airways where it branches off even more, and these are called bronchioles. Okay. So when it comes to the respiratory, and then eventually we get down to the alveoli. Okay. Alveoli. So this, you just have to know your anatomy for everything. But
Hmm.
so we've got a nose, we've got a mouth, we've got the oral pharynx, and then a little lower. So we've got an oral pharynx, we have a nasal pharynx, and then they come together at the pharynx, and then the lower part of that is called the hypopharynx. Hypo meaning low or underactive. So underneath the pharynx is the hypopharynx. Then we have our larynx. That's the entrance to that's the voice box. That's the entrance to the trachea. The trachea, we recognize it by these cartilaginous rings. This bifurcation or this split where it branches off into the left side versus the right side, that split is the carina. Okay. The carina happens to be at the level of about, so this is the carina, happens to be at the level of T4. That's just a good thing to know. So it's about the fourth thoracic vertebrae is about the level of the carina at the level of T4. So croup. Croup is inflammation of the larynx, trachea, and bronchioles. Not bronchi, but bronchioles. So we have the larynx, trachea, bronchioles. That's croup. Well, of course, the bronchi is in between. But if we have inflammation of all this stuff, that's croup. Okay?
Gotcha.
So croup, this stuff gets all the way down to, especially when we're at the bronchiole level, we're down to the lower airways. So that's primarily going to be a lower airway obstruction. Okay? But now what is croup? It's primarily due to a viral infection. And viral infections are gradual onset versus slow onset.
Mm-hmm.
Okay? Now let's talk about epiglottitis. So an epiglottitis, so let's break it down. Epiglottitis, inflammation of the
Epiglottis.
epiglottis. Where's the epiglottis? Well, the epiglottis is, okay, so we have the larynx, and then, so we have the trachea, okay, and then like there are actually two tubes. So let's do it side by side. I'm gonna put trachea in blue because that's going to the lungs, and then sitting right behind that, we have the esophagus. So this is our trachea, and then behind the trachea, we have the esophagus. Okay.
Mm-hmm.
Of course, the trachea ends up going into the lungs. The esophagus goes into the what?
Your stomach.
Goes into the stomach. This is why we have to be careful that we don't put too much air in somebody when we're breathing for them, because we can actually cause air to end up going down the esophagus into the stomach. We make the stomach bigger, bigger, bigger. Now
Mm-hmm.
but because it's inside of skin and all of that, it starts getting bigger, 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 pressing on the inferior vena cava. And now you stop blood coming back to the heart. Now let's go back to where we were though. So we have the trachea and we have the esophagus. Well, there's this little flap right here. There's this little flap that closes. Well, it doesn't close like that. It closes. There's this little flap that covers the trachea, like when you swallow, so that the food goes down the esophagus and not down the trachea. That little flap is what's called the epiglottis. So
Mm-hmm.
notice where it is. The epiglottis is pretty high up. So that's going to be like up here in the upper airway. Okay?
Gotcha.
So
Mm-hmm.
epiglottitis is primarily going to be in more of an upper airway situation, versus croup affects down in the lower airways. But I'm not memorizing it. I just come up with a picture and then I just know the picture. Okay?
Yeah.
So
Okay.
epiglottitis primarily affects what part of the airway? Upper or lower?
Upper.
Okay? Primarily affects the upper airway, where we have an inflammation of the little flap that covers the trachea.
Mm-hmm.
Okay? What causes it? So if croup is primarily caused by a viral infection, and the virus is going to be parainfluenza virus, primarily.
Mm-hmm.
It could also be RSV, respiratory syncytial virus. All right, now let's talk about epiglottitis. It's primarily caused by a bacterial infection. Bacterial infections, because bacteria divide so quickly, like you take something like E. coli, it can divide in about 20 minutes. Like you got double the amount in just 20 minutes. So bacterial infections spread quickly. So it's going to be more of a sudden onset instead of slow onset. So it happens quickly. This is why it's so life-threatening, because all those bacteria, like you start off with 2. 20 minutes later, you got 4. 20 minutes after that, you got 8. And then it just quickly divides. Okay?
Mm-hmm.
The most common bacteria is Haemophilus influenza type B, It could also be strep. You don't have to know this part. It could also be strep, like streptococcus. It could also be staph, like staphylococcus. Okay, but those are all bacteria. Okay, Haemophilus, streptococcus, staphylococcus. Those are all bacteria that cause a sudden onset. Now, if we have swelling of the airway, or any swelling can cause the airway to narrow. Okay,
Mhm.
if we have narrowing of the upper airways, what's that called? What's it called?
Okay, Stridor.
Stridor. Okay, and you must know this. Narrowing
Yes.
of the upper airway is stridor. Okay, narrowing somewhere down in the lower airway, what's that called?
Is that wheezing?
It is.
Okay.
Okay, so wheezing is narrowing of the lower airway. Stridor is narrowing of the upper airway. You got me going way over time. That's okay.
No, I said it was a big
That's all right.
question.
That's fine. So now, but stridor can be due to not just epiglottitis. It can be anything that causes an airway. Let's say we have a burn. They inhale gases that burn their upper airway. That can cause stridor. They have an allergic reaction that gets really severe called anaphylaxis. That can cause stridor. Stridor is just a sound. Wheezing is
Okay.
just a sound. Yeah, so wheezing can be caused by asthma. Wheezing can be caused by COPD exacerbation. Wheezing can be, you can have cardiac wheezing with pulmonary edema. Those are just sounds. You want to know stridor is the sound due to a narrowing of the upper airway for lots of reasons. Wheezing is a sound due to narrowing of the lower airway for lots of reasons. Um,
Mhm.
when do you typically hear stridor? Stridor is typically heard on inhalation. So when you inhale, so it's called inspiratory stridor. Wheezing, on the other hand, can be due to inhalation or exhalation. So you can
Mm.
have inspiratory or expiratory stridor. Wait a minute. What am I writing here? That's supposed to be inhale. Okay. This is definitely basic stuff to know, though. So
Yeah,
you really want to master this. Did that answer that question?
it did. Thank you.
Okay. So I want you to here. Let's go. You ready? All right, Kayla. It's me and you. It's us
Okay.
against the world. Let's go. Okay. So I want you to picture the airway, right? So
Mhm.
how do we breathe? When we first breathe in, air goes through. We got two ways to get it in normally, unless there's a hole in the neck. And by
Mhm.
the way, what would that hole in the neck be called?
Oh, I know it's not coming on the top of my head.
Okay, that hole in the neck, that's going to be a stoma.
Stephanie? Stoma. There we go. I'm
Okay,
gonna start with an S.
so that hole in the neck is going to be a stoma, stoma. But typically, most people don't have a hole in their neck. So most people get air either through their nose or their mouth. Okay. So inhale through their, oh, by the way, let's go over respirations because this is a big thing. When I breathe in, so I'm either going to breathe in or I'm going to breathe out. Those are my options, right? Now, when I breathe in, what makes me breathe in? What makes you take your next breath right now?
What's the excess of CO2?
Ooh, okay. I like it. Okay. All right. So the excess of CO2, what would I call that, by the way? If I'm talking about medical terminology, what would I call an excess CO2?
Um, is that with our ventilation or not ventilation?
Okay. So
Oh
excess
God.
is hyper. And when we're talking about CO2, sometimes it'll be referred to as carby or capne. So if they have
Okay.
hypercapnia, so it's either
Capne.
hypercarbia or hypercapnia. That's excess CO2. So this is CO2, this is CO2. Hypercapnia, hypercarbia. Those are excess CO2. So typically for normal healthy lungs, it's an excess CO2 that causes you to breathe. Now, where in your body is it figuring out you got too much CO2? Where's that? where's the sensor for that?
Um, is it in your alveoli or the capillaries? Um,
You know where I'm
I
drawing
think
right now?
oh, in your brain.
Okay, so this
Brain.
part, all
Yeah,
right, so this right here is the brain. This
brain.
right here is the
Yeah.
brain stem, and the
Okay.
brain stem is what feeds into the what? Spinal cord.
Mm-hmm.
Okay. So you definitely got a lot to review. Okay, not putting you on the
Yeah.
spot, but it's
No,
not
it's
just you. It's most people. Okay. So let's go over this very top part. So this is the brain, right? And then we have, so that's what we would call the cerebrum. Then we got this
mm-hmm.
part at the back here that's involved in muscle coordination. What's that called?
Cerebellum.
That's your cerebellum. It's involved in movement and muscle coordination. Then we have the brain stem. Now, this first part right here of the brain stem, that's called the midbrain. Then this next part here is called the pons. And then this last part is called the medulla oblongata. Okay. In the medulla oblongata, that's where your respiratory center is located. So that's the part that detects, oh, we got too much CO2. Or for people who have COPD, it detects that we have not enough oxygen. So the two triggers to breathe are either too much CO2 or too little oxygen. Okay. So they're located here, and they're also located in the aortic arch. So the aortic arch, that's going to be, so here's your heart. And as blood leaves this left ventricle, it goes through a valve, the aortic valve, and then it goes into this aorta. And then there's an arch.
Mm-hmm.
And there are these branches off the arch. But
Mm-hmm.
inside the arch, that's where these other chemoreceptors are. Okay. So you have them in the carotid sinus. Okay, and then they're there, and they're also in the carotid sinus, which is here. So here. Okay. So these things detect that you have too much CO2 or not enough oxygen, and then they cause you to breathe. Now, when you breathe, what happens? So air now rushes into either your nose or your mouth, and it goes in, and you keep breathing in until when? Like, what makes you stop breathing in? When do you stop breathing in? All right. So this way I want you to think of it. So you have your lungs.
Mm-hmm.
And then let's just call that lungs. Okay. So you've got the outside world. And okay, this is the outside world. And this is the inside world.
Mm-hmm.
What makes the air go in is when first the pressure is higher on the outside and it's low on the inside. So when this pressure is higher, air goes from high to low, or pressure goes from high to low. So that's what makes you breathe in. But you keep breathing in until the pressures are equal.
Mm-hmm.
And now once the pressure inside and the pressure outside are equal, so I should have done it this way. When this pressure is high and this pressure is low, air goes in. You keep
Gotcha.
breathing in until the pressures are equal.
Right.
And
Okay.
then once the pressure on the inside is high and the pressure on the outside is low, which way does the air go? It always goes from
Out.
high to low.
Mm-hmm.
So which way does it go then?
Out.
Out. That's what makes you breathe out. So what makes you breathe in is pressure that's high from the outside. What makes you breathe out is pressure that's high on the inside.
Mm-hmm.
So that's what's called a pressure gradient. A gradient just means it's different. If the pressures are the same, there's no gradient. Gradient means one side is high, one side is low. Does that make sense? So
Yes.
repeat that. First of all, tell me what's the trigger that makes us breathe, and then what actually causes the air to rush in or rush out.
Okay. What causes us to breathe is we have too much CO2.
Okay, and where does that get detected? Give me two places.
Um, up in the don't tell me. I just have to think about it real quick. In the brainstem
Okay,
through
what part of the
the
brain stem?
it's called the medulla um
Medulla oblongata.
oh, I got it.
Okay,
Yep.
in the medulla oblongata, say it again. The what?
Medulla oblongata.
Yeah, that's right. The movie Waterboy. That's right. Okay, so in the medulla oblongata, and where else are these? These are called chemoreceptors. Where else are these chemoreceptors located?
um in the well, it travels down through the spinal cord, and then isn't it in that little aorta arch?
Okay, so the aortic arch, and I
Mhm.
misspoke. This is called a baroreceptor in the carotid sinus. It's actually a chemoreceptor in what's called the carotid body. Carotid
Mhm.
body, but it's in the carotid, it's in the neck, but
Right.
it's in the carotid body, not carotid sinus. I
Okay.
misspoke there.
Okay.
Carotid sinus is for baroreceptors. Carotid body
Okay.
is for chemoreceptors. Okay, anyway, so it's in the heart and it's in the brainstem. Those are where your
Mhm.
big chemoreceptors are located. Now, so that actually causes let's talk about the physiology of respirations. So what makes the air go in again?
Um, is this that part now where it's the pressure is
Yep,
high on the outside? Okay.
that's right. So the atmospheric pressure is high. The
Mm-hmm.
pressure inside the chest is low.
Oh.
So this is called atmospheric pressure. This is called intrathoracic pressure. Okay. What makes you breathe in is when the atmospheric pressure is high and the
Mm-hmm.
intrathoracic pressure is low. Now air goes in. And it keeps going in until what happens? When is the thing that makes it say, all right, no more air in?
When the inside pressure is it higher or is it when it's level or
It's
when
level.
it's yeah.
So when they're level, there's no high side, there's no low side, so there's no movement of air. Air only moves when one side is higher than the other.
Mm-hmm.
Okay?
Okay.
So when both let's do them as like boxes. So when this pressure and this pressure are equal, does air move? Yes or no?
No.
No. But when this side is bigger, which way does the air move?
In.
Okay? When this side is bigger, which way does the air move?
Out.
Okay, got it. All right, you got that part. Now, what's actually making the air, like what allows the air to go in or not? So, I need another page. See, I didn't know we were going here, but I'm always ready. Okay. So, all right, so here's your lungs, right? Let's just put some lungs in there and boom. Let's call that lungs. Then there's this big muscle that separates the chest from the abdomen. What's that big muscle called?
Your diaphragm.
This is the diaphragm, okay? The position that I just drew it in, that's the diaphragm at rest. All right, so this is the diaphragm at rest
Mm-hmm.
versus when you inhale. Okay, hold on. Let's do it this way. When you inhale, the diaphragm goes to this position.
Mm-hmm.
Okay. So the diaphragm actually moves down. So we call that constricts or contract.
Mm-hmm.
So, and that happens during inhalation. Now, because this muscle had to constrict, the muscle had to do some work. So that's called active. So inhalation is active. On the other hand, when you exhale, the diaphragm goes back up to this normal position, but it just does it. Like it doesn't have to work to relax.
Right.
It just happens. So this is where the diaphragm relaxes. Think about it, when you are working versus when you're just chilling. When you're chilling, you're not working, right? So this is during exhalation, and this is called passive. So exhalation is typically passive, inhalation is working under normal conditions. However, if you're in distress, so if you're in respiratory distress, let's put that in blue. So if you're in respiratory distress, which is what kind of problem? Is it oxygenation, ventilation, or perfusion?
Um, Oxygenation.
Okay, it's an oxygenation problem. Okay. Now you've got like an increased heart rate, an increased respiratory rate. So now if you're struggling to breathe, of course, those options can be mild respiratory distress, moderate respiratory distress, severe respiratory distress. Now,
Hmm.
let's say you're struggling to breathe. So then what happens is now you're having to use other muscles to help you breathe in. Now, where do you have other muscles that come in and start doing some work? What other muscles can I pull on to help me breathe?
Your neck muscles,
Okay.
your abdominal muscles.
So these
Uh,
muscles in the neck, what are they
mhm.
called?
Um, it's not coming to my head right now.
Okay.
Sca-
I, I just drew it. I just wrote it. What is
Scaling.
scalenes? Okay. So we have the scalenes. We also have these other ones that are on the sides, on both sides. You know what this stands for?
No.
Okay. It's sternocleidomastoid. Let's break all that down. Sterno. What body part sounds like sterno?
Sternum.
Sternum. Okay. Cleido, that means clavicle. Mastoid, your mastoid bones are over here. So these muscles in the neck are the muscles that activate uh, the muscles near the mastoid,
Hmm.
the collarbone, and your sternum. So the muscle that kind of sits between all of that, that's called the sternocleidomastoid. Okay. So we have the scalenes, the sternocleidomastoid, and then we also have other muscles that get used are our abdominal muscles. Okay. You should not normally have to use these to breathe, but this is why if you see somebody and they're using all these accessory muscles, like muscles in their neck are moving when they breathe, or their belly is moving when they breathe, these are signs of respiratory distress or severe respiratory, moderate or severe respiratory distress. Does that make sense?
Yes.
Okay. Um, hmm, okay. So, all right, here, you tell me this back. I want you to teach this back to me. Teach me about inhalation, exhalation, what makes you breathe in terms of the pressure difference, whether it's active or passive. Let's go. And I'm going to leave the picture up for you.
Okay. All right. Well, when we inhale, it's an active part of breathing, and so the diaphragm gets constricted. And then when we have respiratory distress, then that can cause someone to use um, their neck muscles or their abdominal muscles, and that it becomes an oxygenation problem.
Okay.
And
And that oxygenation problem can be called mild respiratory distress, moderate respiratory distress, or severe respiratory distress. Now, what if they're in
yes,
mild respiratory distress? Okay, they're struggling to breathe. What kind of oxygen delivery device could I use for mild respiratory distress?
um, could you use a nasal cannula?
A nasal cannula. How are we going to flow it?
1 to 6,
1 to 6 liters per minute. What if it's a capnography nasal cannula?
1 to 5.
Check you out. Okay, that's going to be 1 to 5. Now, what if they're in moderate respiratory distress? What kind of airway delivery device would I use?
Would we use a non-rebreather?
Non-rebreather, I'm going to flow it how?
Um, I want to say 10 to 15,
Just
but
say 12. 10 would work, but I say 12 to 15 liters per minute. Okay.
okay,
Because if
12 to
if
15.
they're really struggling, I'm probably going to just start them with 12. Okay.
Okay.
12 to 15 liters per minute. What if I'm going to use a nebulizer?
Um, 6 to 8.
6 to 8 liters per minute. Okay. Let's say they're in severe respiratory distress. What's our oxygen delivery device probably going to be?
Oh. Okay, it is a CPAP. See, I was getting confused. I was like, gosh, is the CPAP for the ventilation? Because I know the BVM is for the ventilation, but I was
Okay.
looking at,
So,
okay, so
so you
CPAP
want to
for the,
think of ventilation problem is where I have to help them out.
yes.
Okay. CPAP, they got to do the work themselves. They got to breathe on their own.
Okay.
Ventilation is where they're not able to do it on their own. They're getting too tired or they're just not breathing at all. They have respiratory arrest. Um,
Mhm.
and then that's where I'm going to help them out. But CPAP, they've got to be able to follow commands. They can't have any contraindication, but they still got to be able to do the work themselves because they have to actually suck the air in. Okay.
Right.
Even though the machine is working, but they still have to breathe on their own. All
Okay.
right. Okay. Now tell me what's the trigger that makes them breathe in the first place. Let's go back to that.
Is this the part where we're talking about like with um, the two places where,
Okay. So what are the two triggers? What's the normal trigger? And then what if you have like unhealthy lungs or diseased lungs? What's the trigger for normal healthy lungs?
um, well, is this the one we're talking about, the medulla oblongata?
It is. Well,
That
that's
one?
a
Or,
structure. That's where it's happening. But first of all,
yeah.
what is the trigger? So it's either
Where
triggering that we
too
have
much,
too much of something or too little of something.
yeah, where we have too much CO2.
Okay, in normal healthy lungs, it's too much CO2. But
Mm-hmm.
if they have like COPD, it's too
Mm-hmm.
little oxygen.
Right.
Those are the two
Okay.
triggers. The triggers are either too much carbon dioxide for normal people, and when I say
Mm-hmm.
normal people, I mean normal lungs. Or
Right.
if they have problems with their lungs, their trigger is too little oxygen. Those are the options. Okay. Both of these situations are detected by the chemoreceptors in the medulla oblongata and the aortic arch and the carotid body. Okay? Those are called what are these things called that detect CO2 or O2? What are they called? Cuz these things are chemicals. So what are the
Mm-hmm.
receptors that detect chemicals?
Oh,
Chemo receptors.
okay. Chemoreceptors.
Okay? You have chemoreceptors and then you have baroreceptors. Baro means pressure. So baroreceptors either detect high or low blood pressure.
Gotcha.
Okay.
Okay.
Chemoreceptors detect either high CO2 or low oxygen. Okay. You got that again? Give me that back.
Yeah.
Teach that back to me.
Okay. So chemoreceptors uh detect high CO2 and low O2,
Okay. Where
and
are those
then
chemoreceptors located?
in the medulla oblongata,
Medulla oblongata. What else?
and then the aorta arch,
Aortic arch
aortic
and the
arch. Oh,
carotid
carotid
body.
body.
Carotid body. You have a carotid sinus, carotid body. Both of them are in the carotids. They're close to each other. They're just called different things. Okay,
Hmm.
that's cool. Now, when your chemoreceptors say, "Ooh, they got too much CO2, we need to make them breathe," air goes in as long as. Tell me about the pressure part.
Air goes in as long as there's lower pressure inside,
Okay,
and
so
so
that's called a lower. What kind of pressure? It's either what's this pressure on the outside called?
Oh,
That's out there in the
um,
environment, in the
yep,
atmosphere. So
atmospheric.
that's
Yep,
called atmospheric pressure.
yep, atmospheric pressure.
And then the pressure inside the chest cavity is called the,
Hypo something, hypo.
no, that's called,
Oh,
it's within, it's within the thorax.
okay.
So the word for within is intra.
Oh, okay.
So
Intrathorac.
intrathoracic.
Okay.
Okay. Oh, these are good suffixes to know. Hold on, let's add that to the list. So, or these are prefixes. So, inter,
Mm-hmm.
intra, inter means between, intra means within. So, within the thorax is intrathoracic. Within the abdomen is intra-abdominal. Within the brain is intracerebral. Okay. All right. Now, if the atmospheric pressure is high and the intrathoracic pressure is low, air moves which way?
In
In. And when you breathe in, is that called inhalation or exhalation?
inhalation,
Is that going to be active or passive?
active.
Okay. And what's the main muscle that should get used during inhalation only? What's the muscle that
Your
should be used?
your diaphragm.
Okay. And which way does the diaphragm move when you inhale?
Down.
It moves down. We call that constriction or contraction. Okay.
Mm-hmm.
Now, that's in normal situations. Now, when you normally breathe in, how much air do you move?
When you breathe in,
Yep. So, our normal breathing in or breathing out, what is the amount of air that we normally breathe in or normally breathe out? And I keep stressing normally because this is when we're just like sitting here right now. How much air gets normally moved in or out?
are you like asking to like percentage wise or just
Volume
like
wise.
volume?
So it's about
Oh,
500 milliliters of air, and that is called your what is the volume of air that normally gets moved in or out? What's that called? That's called tidal volume.
right.
So our normal
Okay.
tidal volume, a normal tide, what goes in, so you know how the tide in the ocean it goes in and out. So our
Yeah.
normal tide is about 500 milliliters of air. Okay. This
Okay.
is why when you happen to ventilate somebody with a bag valve mask, because that bag valve mask, here's your bag, and then here's your little tube, and here's your mask, right? Your bag
Yep.
valve mask, how much air does that hold? It holds
I can't
about
remember.
1,500 milliliters of air. So if you
Okay.
squeeze all of that air out of the bag one full time with one hand or two hands, you're putting way too much air in their lungs because their lungs normally only hold about 500 milliliters of air, and they don't even use all of that. They only use
Right.
about 350 milliliters because some of it is just kind of hanging out in this dead space.
Right.
Okay. So if you squeeze this whole bag, you're giving them way too much. This is why you want to gently squeeze the bag with about 2 fingers. Well,
Mm-hmm.
3 fingers, like your thumb and 2 fingers. That's about all the air they get, just enough to make the chest rise. Because
Right.
otherwise, you're giving them way more than their normal tidal volume. Okay. That's normal breathing. Now, what if we take a really deep breath in because we're struggling? Now we're going to have to use different accessory muscles, such as
Our scalenes in the neck
scalenes,
and then the sterno
Clydo,
uh Clido
mastoid.
mastoid.
So put it
Yeah.
all together and you have the,
SCM.
but if
Uh,
you, so what is
sterno
SEM?
sorry, sternocleidomastoid.
Yeah, the SEM is sternocleidomastoid. So we have the scalenes, we have the sternocleidomastoids, and then we also have the abdominal. Oh, and then the ones between the ribs, those are the intercostals.
Oh yeah, there is those ones too. Yeah.
Okay, inter meaning between rib, costal is rib. between ribs is intercostals. Okay, those are the accessory muscles. Tell me the accessory muscles that we have to use, especially when we can't get air in, when we have an oxygenation problem like respiratory distress.
So list all the ones. Okay.
Let's go.
So we have the sternocleidomastoid, the,
Sternocleidomastoid. What else?
the scalenes,
Scalenes. What else?
the intercostal muscles.
Intercostal and then intra-abdominal. And
Yep.
then these intra-abdominal, they are called the external and internal. Okay, but we're just going to call it intra-abdominal muscles. Okay, now when you take a deep breath in, this is what happens. So let's say so what I just drew here, this is normal ventilation. But let me show you what happens if you take a real deep breath in. It looks like this. Instead of a normal tidal volume, when it goes up, that's inhalation. It's a really deep breath in like that. That's a deep inhalation. So this is what's called the inspiratory reserve volume. Okay? Or if we take and we do a really deep breath out, that's called the expiratory reserve volume.
Okay.
Okay? Did you learn this part?
Yes, I learned it through one of your videos.
Okay, but what about in school?
I did learn it in school. It's just when they did it, it was very fast, so it was more of like me reading it in the book and
Okay.
all that.
And then,
Yeah.
okay, so these are some, so what is the normal amount of air that gets moved? What is this volume called? Or this one right here?
Tidal
What's
volume.
that volume called?
Tidal volume.
Tidal volume. When you take a deep breath in, what's that called?
Um, oh,
Inspiratory
inspiratory.
reserve volume.
Um,
When you take
yep.
when you go and really blow it out, what's that called?
X.
Expiratory reserve volume. And then there's also a little air that's kind of let's move this line. Okay. There's a little air. Let's do my line here. There's a little air that's left over down here, and that's called residual volume. Okay. So the main four volumes you want to know in the lungs, we have what's called a tidal volume, an inspiratory reserve volume. That's where you take a really deep breath in. Expiratory reserve volume, that's where you take a really deep breath out. And then the part that's still left, there's always a little bit left over way down in the alveoli, and that's going to be your what's called your residual volume. That's the part that keeps the alveoli open so that it's kind of like a balloon. You don't want that balloon to slam completely shut because it's going to take so much effort to make your next breath. So there's a little air that stays in there to make it easier to breathe. That little air that's left over that you never get rid of, hopefully, that's called your residual volume. Now, when I add up all these volumes, when I add up tidal volume plus inspiratory reserve volume plus expiratory reserve volume plus residual volume, when I add up all of those, this whole thing is called total lung capacity. Okay?
Right.
Those
Okay.
are like the volumes to know. So I gave you 5. What's total lung capacity?
It's where you add up your tidal volume, your inspiratory, expiratory, and your residual
Okay.
volume.
Yep. That's total lung capacity. What's tidal volume? This
It's
part right here.
the normal um normal breathing.
Yeah, it's about the normal amount that you breathe in and out with a normal breath when you're at rest. How much air should normally move in or out with your tidal volume?
500
About
milliliters.
500 milliliters. Why should you not squeeze the whole bag?
Because you'll give them more than what they need.
Okay, and if I give them more than what they need, what happens? I take air instead of pushing it in the trachea. Where does this excess air go?
Does it go into the stomach?
It goes down the
It's
esophagus into the stomach. I make the pressure inside the stomach bigger, 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 bigger. What do I press on?
Your no, superior vena cava,
Well, it's the one
or
coming from the
no,
bottom, so that's the
the inferior vena
inferior vena
cava.
cava. Okay, cool. Notice how much stuff we tied in this one picture?
Yeah.
So here's what I want you to do. I want you to redraw this yourself. I want you to so here's what I want you to do.
Okay.
I want you to take a blank sheet of paper or a dry erase board or whatever. And I want you to
Okay.
do exactly what I did today.
Okay.
All right. So, Johnny, we're about done. We're like way over time. But Kayla just wanted to hang out extra with me. So, what I'm going to have you do, Johnny, is go back over the replay because we covered a lot today. But so we covered thyroid, like hyperthyroid, hypothyroid, myxedema coma, thyroid storm. We went over blood pressure medications. Now we're going over airway stuff. We've also gone over medical terminology. So there's been a lot in today's video. All right. But Kayla, what I want you to do is go back over, take a blank sheet of paper or dry erase board, whatever. Just take a blank screen or whatever you have. And I want you to go back through exactly what we did. Okay. Draw out an airway, starting with the nose and the mouth, then going into the nasopharynx or the oral pharynx, those converging in the pharynx. Below the pharynx, we have the hypopharynx. Then we have the larynx. Okay. We talked about epiglottitis. We talked about croup. Draw out the whole airway from after we go through the larynx, then we go to the trachea, then we go to we have the left. Well, first it splits at the carina. What's the level of the carina? What vertebrae does it correlate to?
E4.
Okay, about the level of T4. Okay, then we split into the left main stem bronchus, the right main stem bronchus. If we have two of we don't call them bronchuses, we call them bronchi. So if we have the left bronchi, the right, or if we're talking both, we say bronchi. Then it gets down into the bronchioles. Then it gets down into the alveoli. We talked about croup being what kind of infection?
Viral.
Viral. Does it happen quickly or slowly?
Slowly.
Gradual onset. What's the number one virus?
Oh, I can't remember that one. I can remember the
Parainfluenza
epiglottis one.
virus. What's the other virus? Respiratory syncytial virus. Okay. What's the name of croup?
Uh, the layer.
Laryngo,
Was it laryngo,
tracheo,
brachio,
bronchiolitis.
bronchiolitis.
Laryngotracheobronchiolitis. Say it again.
Oh, layer. Oh gosh, laryngo, trachea,
Say it
bronchiolitis.
again. One more time.
Laryngo, trachea,
Laryngo,
laryngo. Okay,
uh-huh,
laryngo, break, trachea,
tracheo,
bronchiolitis. Tracheo. That's right, all the O's.
uh-huh,
Uh, bronchiolitis.
bronchio, or bronchiolitis. Laryngotracheobronchiolitis. Say it again.
Laryngo, tracheo,
Check
bronchiolitis.
you out. Okay. Laryngotracheobronchiolitis, and that's going to produce a seal-like barking cough. So we say that we have CC'd, so croupy cough with a seal-like barking cough. All right. Tell me about epiglottitis.
Epiglottitis is more of drooling, and it's a bacterial, and
Okay.
so it's sudden. And it's in the upper airway.
Okay.
And then three causes for is
Three main bacteria. So Hib,
bacteria.
that's going to be Haemophilus influenza. So Haemophilus influenza type B.
Mhm.
Strep. So that's the infection that causes strep infection. So that's a bacterial in the throat. Um, Staph. So Staphylococcus aureus, Streptococcus pneumoniae. So, okay. We also covered inhalation versus exhalation. We went over stridor versus wheezing.
Mhm.
Okay. We talked about not putting too much air in the lungs. Then we talked
Yeah.
about your triggers to breathe, your hypercapnia or hypoxia. Okay. Those things we talked about, chemoreceptors, where they're located. Chemoreceptors are located in the medulla oblongata of the brainstem. They're also located in the aortic arch and the carotid body. We talked about baroreceptors. Those are the receptors that detect pressure changes. Those are also in the brainstem, the aortic arch, but they're in the carotid sinus instead of the carotid body. We talked about normal breathing, the physiology of respiration. What makes you breathe in is when you have a high pressure on the outside, a low pressure on the inside, air goes in. And then what makes you stop breathing in or out is when the pressures on the outside and the inside are equal. And then once the pressure on the inside is big or high and the pressure on the outside is low, that is what causes air to go out. We talked about inhalation being active, where the diaphragm constricts and it goes from this position down to this position. Okay. We talked about during exhalation, this diaphragm just kind of relaxes and it goes back into this dome shape. And that's exhalation is passive. We also talked about your normal volumes. So we have a tidal volume, we have an inspiratory reserve volume, we have an expiratory reserve volume, and a residual volume. When I add them all up together, that equals total lung capacity. I want you, so here's what I want you to do. You ready? Will you promise me you'll do this?
Yes.
Say, Coach, I promise.
Coach, I promise.
Okay, I want you to take a blank sheet of paper, but don't just do it. The only way I'm going to know you do it is I need you to record a video of you doing it. And I want you to teach it back and be as detailed as possible without notes. Okay. If you need to go back, and I'm telling you, these pictures will help you come up with a lot of information because you can just use the picture to come up with everything. So I want you to record yourself giving about a 10-minute talk on everything you can think of with respirations and upload it in the community tonight.
Okay.
Or this evening. You got it?
Okay.
Okay, now we're announcing it to the world. Kayla is going to Okay, so I expect to see this today inside the community. And we'll all celebrate with you, but this is going to help you become so much smarter. I promise you. Just do it.
Okay. I
Can I
know, I
count on
believe
you?
you. Yes, I can
Okay.
do that.
And it's going to help you.
Yes.
All right. Anything else? Since you decided to take a whole hour just by yourself. No, that's fine. That's fine. I do accept Cash App, Venmo, and I'm hungry. Lunch sounds great. Uber Eats, DoorDash. No, you're good. Anything else?
Not for me. I know Johnny had a question in
Okay,
the
Johnny,
chat.
what's your question, my man?